Good evening. Good evening. I'm Persia Nicole from Radio One. And this COVID-19 pandemic may have altered the way we live our daily lives, but there's still hope for better days. Hang out with me for the next hour along with our panel as we update you on the COVID-19 vaccine availability and discuss why it is important to get vaccinated. We'll give you the facts about the virus and the vaccines, healthcare disparities, and ways that we can all help each other and, of course, keep our friends and family safe. All right. And so if you've received the vaccine, contracted COVID-19, or have questions for our panel, go ahead and post your questions in the comments section here on Facebook or YouTube and enable closed captions for this event. Go to Facebook settings, then accessibility to turn closed captions on. If you know someone without internet access tonight who needs help with a COVID-related matter, including signing up for vaccinations, ask them to call 1-855-MD-GOVax. Again, that is 1-855-MD-GOVax, or that's 1-855-634-6829. If you have internet access, visit covidlink.maryland.gov to sign up for your vaccination and to get the most up-to-date information on COVID-19. We're going to have an amazing night. Let's go ahead and meet our panel. First up, Dr. Jane Morgan is a cardiologist with experience in clinical patient management and pharmaceutical and biotech research. She's a director of a COVID-19 task force for Piedmont Healthcare Corporation Atlanta, ATL. Dr. Morgan is also a health equity advisor for Moderna. Welcome, Dr. Morgan.
Thank you, Persia. I appreciate being here.
I'm so excited you're here. And the question, of course, everybody wants to know, will our lives ever be the same?
Well, the answer to that is yes. And yet, I hold out hope that it won't be the same. I hold out hope that the lessons that we've learned from this pandemic will allow us to move forward in a better, more open, more understanding society than the one that we left. And I think COVID has uncovered a lot of the societal inequities, health inequities that really had just become normal and commonplace in our society. And I think hopefully as we move towards a post-COVID era, those lessons will allow us to move forward in a more humane, more inclusive way and provide health access really to everyone and begin to narrow the gap in health equity that this COVID pandemic has so exposed.
Yeah, absolutely. Thank you so much, Dr. Morgan. Next, we have Dr. Jin Lee Chan, Acting Deputy Secretary for Public Health Services at the Maryland Department of Health. She has led Maryland's COVID-19 testing task force, overseeing its expansion from a single testing site to more than 240 testing locations. Thank you for joining us, Dr. Chan.
Hi, good evening. I'm so glad to be here.
Absolutely. So now that vaccinations are becoming available, right? More available. A lot of people have wondered, is this still important to get tested?
Yes, absolutely. What we're seeing right now is that, the virus is still circulating and, we are pushing vaccine out as quickly as we can. And here in Maryland, we've had over 2.5 million people vaccinated. But in terms of fully vaccinated, we're at about 15%. And, so we still have a little ways to go. And so anyone who may have been exposed, or even after you've been vaccinated, if you have symptoms, we would still encourage people to get tested. And information is available on our website as to where people can get tested at covidvax.maryland.gov.
Thank you so much, Dr. Chan. Finally, we have Dr. Freeman Rabelski, president of the University of Maryland, Baltimore County. Dr. Rabelski is also a consultant on science and health education to national agencies and a participant in the Moderna vaccine trial studies. Welcome, Dr. Rabelski.
Great. Good to be here. Thank you.
So for you, why would you think it's important for people to enroll in the Moderna trial?
Sure. My wife, Jackie, and I decided to participate probably in September. And we did so because I'd been talking to one of our graduates from UMBC, Dr. Kizzmekia Corbett, who led the NIH team in developing the technology and the vaccine for COVID-19. And she was telling me that they were having a hard time at that point increasing the number of African Americans willing to be in the trial. And people were asking me a lot about it. And they also knew that I was from Alabama and would be familiar with the Tuskegee study and the issues we've had even at Hopkins. And so we were having those conversations. And what I could say to them was, I was convinced that this was very safe. We produce a lot of scientists and doctors, a number of people who work at NIH, but Dr. Corbett was over this, and I have great confidence in her, quite frankly. And let me just say, It gives me goosebumps to say she's the first Black woman in the world to ever create a vaccine. So it's a big deal, and there's a reason for trust. So we did go through it in September, and we found out a few months ago that in the unblinding visit that we actually had gotten the vaccine, the Moderna vaccine. Her technology, though, is in Johnson & Johnson, Pfizer, and Moderna.
Okay. Thank you so much, Dr. Rabelski. And thanks to all of our panelists for taking part in today's, of course, COVID-19 town meeting. And if you have a question about COVID-19 vaccination, or if you have had COVID-19, send us a message in the comments and we'll get you right in the conversation. Let's get this started with the basics. What is the COVID-19 virus? How does this virus affect us all? You know, a lot of people want to know what exactly it is, where it came from, how did it pop up? Dr. Chan, do you want to take this question on?
Sure. So the COVID-19 virus is actually part of a family that can also cause colds. And so, so we've seen this kind of virus before, but this particular one that causes COVID-19 in particular is new, which is why everyone has been paying such close attention to this, and this has really impacted all of us across, not only here in Maryland, but across the world, really. And so when we first began to hear reports about it coming out of, not only China, but infecting other, people in other countries, we quickly, ramped up our efforts here in Maryland and, continue on that. With COVID-19, some of the symptoms are very similar to what people might get when they have a cold. So a fever, a cough, runny nose, headache, fatigue, but other things have also come up that we've noticed as we've gotten more experience with seeing people who've gotten infected. And so some of the unusual ones, also loss of smell, people also have experienced diarrhea and other symptoms as well. And while the majority of people actually who get symptoms do fairly well, unfortunately, and we have seen this, affect so many of our families here in Maryland and again across the United States. People are hospitalized and do have died from it. And here in Maryland, it's been over 8,000 individuals. So that's why we continue to work really hard to try to save lives and protect people.
Yeah, and you talked a little bit about the symptoms. Are there any long-term health issues that could stick around from this virus?
So some people long-term, so, days, months after they've recovered from the acute illness, can experience continued symptoms such as that loss of smell, fatigue, and other symptoms that continue to be watched. And so we're continuing to pay close attention to some of the, some people have called it long COVID, and, paying attention to those symptoms and monitoring. And so more studies still to be done. And I know that, others are working on that aspect of it as well.
Okay. Hey, Dr. Morgan, do you know from things that you've heard, do scientists have some type of knowledge as to what impact the vaccine will have on us from years? Like, do they know anything about this?
Right. One of the things that we think about when we think about these COVID vaccines and the clinical trials is that these are all under emergency use authorization, not FDA approval. And what that means is all of the data was not available. So what data was available to qualify for emergency use authorization? All of the safety data was there, so we know the vaccines are safe. All of the efficacy data was available, so we know that the vaccines actually work. But what data was missing? So that immunity data, that long-term data was not available. The FDA required for emergency use authorization 60 days of this follow-up data. And that was what was provided. And so that's why we also can't answer the question regarding, will this be an annual shot like the flu shot? So at this point, we have about 5 or 6 months of data. Next month, we'll have 7 months of data. The month after that, we'll have 8 months of data. That's part of being in a pandemic and having emergency use authorization. So a lot of this information is coming in real time. We will begin to understand where that immunity is long term and whether or not this will be a shot that we need to have every year as the pandemic moves towards an endemic virus in our society, which is where I think it's going, or whether it'll be something that we can spread out over a longer period of time. So that is emergency use authorization, the FDA recognizing that our population was at risk, that we had an inordinate amount of deaths, that we could not afford to wait another 1 or 2 years for all of the data to become available for full FDA approval, and that there were no other alternative viable therapies or treatments available. So we have emergency use authorization. We know the safety, we know the efficacy. What we don't have is long-term immunity data. So I tell everybody to stay tuned.
Okay, we're definitely staying tuned. A lot of people have tons of questions. And I want to remind you, as you're watching today on YouTube or Facebook, go ahead and leave a comment and we'll read it live if you have any questions or comment for our panelists today. A question that many people have wondered is, does the virus affect various racial groups differently? And if so, how? Like Dr. Rabelski, I know that you have participated in the Moderna trial. For you, what do you think on this?
You know, people have been asking that question a lot. And keep in mind that I'm a mathematician, not a physician. Let me be very clear about that. So I'm speaking as a layman now when I say this. But the fact is that we do know that because of the different occupations people have, and for a lot of reasons, that people of color have been affected disproportionately more, quite frankly, and that we've had more deaths, quite frankly. And what that says is it's very important for people of all races to get the vaccination now. You know, and what I would also add is that somehow, I think Dr. Morgan said it well, what the COVID pandemic is showing us is light on all the inequities in our society. People who are wealthy were able to stay home, for example, didn't have to get out as much, can use laptops and get work done. People with fewer advantages were out there. And so we do see that people of color and people from low-income backgrounds are more at risk because of a number of factors about where they live, where they work, when they have to get out, and those kinds of things. So it's important to talk about those of us, African Americans, for example, who were part of the study, and that we're doing fine, and that we truly believe it's important for all people to be vaccinated. Very important.
Yeah, absolutely.
Dr. Morgan, a question. As an educator, she said move from pandemic to endemic. Now, some people might know what that means, but I want you to break it down a little, Dr. Morgan, for us. I'm speaking as an educator. Yeah. Tell us the difference, if you would.
You know what? That's a great point. And I apologize for using that term. You're absolutely right. So we're in a pandemic, meaning we're in the active stages, really, of this virus, trying to get ahead of these mutations, trying to get us immunized and up to herd immunity such that we have protection within our society. But what endemic means is sort of like the flu. At some low level, it may always be within our society, or at least within our society to a certain degree. And that's one of the reasons why, even after we are vaccinated now, we want to continue with public health measures to wear a mask, wash your hands, practice social distancing until we can get up to this level of where we feel comfortable that we have great protection for our society as a whole. So that's the difference between pandemic. Pandemic is what we're in with COVID-19. Endemic, example of that would be the flu or measles, something that's sort of always around, but we have to learn to manage it and live with it.
And Persia, for students, this idea of public health is becoming really a hot area. People are more now than ever are thinking about majoring, you know, of course, science and medicine, but public health is new to most people, which is very impressive.
Yeah, I think like throughout this whole pandemic that we're in right now, it really has made me more aware of my surroundings and what's going on. And I've researched so much. Like, you know, I mean, I feel like I'm actually in school as much as I read about this pandemic and, you know, everything that's going on, the difference between the flu and COVID-19, because it's a lot of similarities and people are, you know, have so many different questions. So like, yeah, I agree. Definitely, Dr. Rabelski. People are definitely more interested in this now, and as they should be.
Yep.
Yeah. I want to bring it back really quick to the conversation of the African-American community. Do you think that there was enough Black representation in the clinical trials? You know, Dr. Morgan, Dr. Chan, Dr. Rabelski, let's talk about this, because a lot of people have issues with that. They feel like not enough Black people were represented in these trials.
Yeah, certainly when you look at the trials, and I'll just start off the answer. We look at the Pfizer trials, they enrolled 40,000 people. There were between 9.3 and 9.8% African-American representation. We look at the Moderna trials at 10.3%. representation. And the Johnson & Johnson trial, another 40,000 people, had 13% representation of African Americans. And if you include Africans in that trial, it was 19%. So while these numbers don't actually represent our percentage in the actual population, the mosaic of America, we are 13.4% of the population. They certainly were impressive, and they demonstrated that these companies were both intentional and purposeful in working to be inclusive and to recruit people of color into these trials such that there could be confidence that the data that was presented to the FDA was relevant to all populations, including the African American population. By and large, we don't participate in research for a number of historical reasons. We have a lot of distrust, not only of research, but of the healthcare system. In fact, we probably participate at 5% or less. So for these companies to have 9.3%, 10.3%, 13%, that was very intentional, very purposeful. And while they fell short of our representation in the population, they did a phenomenal job. I have not seen that degree of representation in clinical trials that were not specific to people of color. And so I hope that this will be a trend that will continue, that we need to be included in trials. Not only do the companies need to pursue people to be in trials, they need to pursue principal investigators, Black physicians to lead these trials such that they can recruit their patients as well. So these are all the areas, I think that are now coming to the forefront that we need to discuss, that need to be open. But absolutely, I think we should have confidence that these trials, certainly these 3 vaccines that are available here in the United States, have representation, not only of the African American population, but extensive representation, really some over-representation of the Latinx population as well.
Yes, yeah. Just a comment adding to that. What I'm saying to people is that we have to trust the scientists, the physicians, and I'm hearing every one of them say that these numbers are very impressive. That, we may be 13% Black, for example, but it's 10% usually that they've gotten to. And it's a very impressive number, meaning that we were substantially represented in the trials. And the other point I would make is just looking at the participants on this panel, having people of color talking about these things from different groups as experts gives people more confidence that people have been, and it does say something going back to what was said earlier, that we hope that when we get out of this period, we remember we need greater representation of women, of people from every racial group as scientists, as physicians, so that people will have more trust in the future.
Yeah, absolutely. I agree 100%. I'm happy we're having this conversation tonight so people that have the questions can get them answered. And we have the experts. So again, as you have maybe questions or comments about our conversation, go ahead and enter them on the comment section. I think we have a question actually now. We're going to pop up on the screen. Okay, so there has been some conflicting information regarding the list of underlying conditions that qualifies someone under phase 2B. What is the final list of conditions that Maryland has decided to use? Dr. Chan, do you want to answer this question?
No, happy to. So the CDC has been doing a lot of research. We have information collected from people over the last year that has provided more information about who is at higher risk of getting complications from COVID if they actually get infected. And so we're actually here in Maryland sticking with the CDC list, which includes people who have who are in active treatment, for example, for cancer, people with immune compromise, including individuals with HIV, certainly individuals who have underlying lung conditions. So if they have like emphysema or any kind of, asthma, cystic fibrosis has been a question as well, and kidney disease. And that's something that we have seen is that individuals who have kidney disease, who need dialysis, or even have any kidney disease are at higher risk of complications. So those are the individuals that as of today actually are now able to get vaccinated at any of our sites across Maryland.
I think another question that a lot of people have wondered is, What is this vaccine? How was it created? And was it rushed? Now, I'm not going to lie. I was definitely one of those people who said this came way too fast. And I'm sure we all have people, friends, family that have all said this vaccine has been created way too fast, right? So let's talk about how the vaccine was made and was it created way too fast? Dr. Morgan, do you want to speak on this?
Sure. So the SARS-CoV-2 virus, severe acute respiratory syndrome, coronavirus 2, this is the virus that causes the disease that we know of as COVID-19. It's so named with that number 2 because that's an alert to all of us in the scientific community that this is the second time that we've seen it. This is not the first time. When did we see it originally? We saw it in 2003 with the first SARS outbreak. That was very concerning because this was an airborne virus. By and large, it was kept off of our shores. We then saw a sister of it in 2012, the MERS virus, Middle Eastern Respiratory Syndrome, by and large was confined to Saudi Arabia. Again, another alert as a part of this coronavirus family that was an airborne virus. In 2020, when we had our first case of COVID-19, those 17 years between the first outbreak of SARS and the first patient that we had already completed all of the preclinical work, all of the bench work research was done, the identification of the spike protein as the primary nidus or the way in which it invades our bodies and connects to those ACE inhibitors, if you've heard that term. The entire genomic sequence, 30,000 base pairs, had already been identified and analyzed. All of that work had taken place in those 17 years before we ever had our first case. That's science going on behind the scene. That's public health happening because that first outbreak in 2003 was a warning to scientists and public health officials. So even though it appeared that it just appeared and suddenly, we began to develop vaccines, that was based on 17 years of research. Additionally, I would say that we also accelerated the development process without compromising any safety. So in general, you have 3 phases of the process, phase 1, phase 2, phase 3, and we overlapped those. So phase 2 started before phase 1 ended. Phase 3 started before phase 2 ended. The reason we were able to do that is number 3, because pretty unlimited resources were applied to this. If you have unlimited resources, meaning money, you can do a lot of things and the companies can take risks. The reason we perform these phases in tandem, meaning we don't start phase 2 until we know all of the data in phase 1, is because it costs millions of dollars to develop this. And we don't want to go to the next phase if the data was not positive in the previous phase. That's a risk that companies take. But in this case, the interim data analysis was very good. They continued to move it forward in a stacked fashion because they had the resources to do so. Resources also mean what? You can hire more scientists. You can pull people from other projects. You can prioritize this one. You can open more study sites. You can enroll more people. The whole thing gets accelerated, right? The last thing is we did is don't forget, we're not under FDA approval. FDA approval would have required, as I said before, another 1 to 2 years of that follow-up data of all of these patients. That's 110,000 patients between these 3 trials. Instead, the FDA only required the 2 months of data and then made it available to the United States under emergency use authorization and allowed the rest of that data to come in month by month. So all 4 of those reasons are why it appears to be accelerated, but it certainly was done carefully, it was done intentionally, and safety was not compromised in any form or fashion.
Persia, let me just add a point as a statistician. When you hear about something being 90% effective, and I would appreciate it if both of the doctors would speak to this. When people have talked about 92% effective, 95%, that's a big deal. It's a really big deal. And I've heard scientists say that people were far more impressed when they got those numbers, didn't know they would be that high. I think it might be helpful to people to hear about what that means when you say something has a level of 95%, 92%, or whatever it is.
Yeah, thank you, Dr. Rabelski. I was going to ask that later, but you got me coming.
Because that's teamwork. I like the numbers. I like the numbers.
Yeah, you're a numbers guy. Yeah. Dr. Chia, do you want to speak on that?
Yeah, so, when we talk about efficacy, it's comparing people who got the vaccine and whether or not they got the disease compared to people who didn't get the vaccine. And so, when we talk about efficacy, it's really about that, that they were 92% basically less likely to get infection. And so, primarily what these vaccines are intended to do is prevent, severe complications from the disease. And that's our first and foremost priority. But those numbers are very impressive. And as Dr. Morgan alluded to, really the bar that we were looking for, that FDA had set, was much lower. They said that, even if it was, I think it was 50% or 60%, and Dr. Morgan, you might be able to speak to that, effective, then we would take it because we knew how much impact the infection was causing across our entire country. And so the fact that we saw 90+% efficacy for both the Pfizer and the Moderna vaccines was really, really important. And even with the Johnson & Johnson, and I want to speak to that a little bit, these are, and this may be another question that people have, is that it's really hard because none of these trials were actually comparing the vaccines to each other. So, when we look at these efficacy numbers, we have to kind of take it in context. And the fact that, all three of the vaccines have been very effective and shown to be effective against preventing that severe disease and hospitalizations and death, that's really what we're very focused on.
Yeah, Dr. Morgan, did you want to speak anything more on that as well?
No, I Dr. Chan is, right on the money. That's exactly correct. We can't compare. It's not apples to apples. It's apples to oranges. And you look at these lower efficacy rates. The other thing that we have to remember or be cognizant of is that Moderna and Pfizer were trialed at a time when these current mutations were not available in the environment. So Johnson & Johnson, even though we look at whatever, 72% efficacy rate, 85, 66, whichever number you're going to review, you have to remember that they were trialing in the UK and Brazil and South Africa when these current variants, these current mutations that are more virulent or more infectious were in the environment and enrolled in their trial. And so their formulation was tested against those. Moderna and Pfizer's were not. It's not their fault. It's just as mutations developed, mutations didn't exist when they were doing their trials. So that's one of the reasons that we hear that Moderna and Pfizer are working on third formulations, because they are aware that as more mutations develop, they need to continue to update their formulation. And it could be that a third shot is coming. Johnson & Johnson may also be in that situation if we don't move seriously towards herd immunity. Johnson & Johnson may also be in that situation where mutations began to develop that were not around when they were doing their trials. And they may be in a situation where they also have to test a second formulation. So we have to understand we're not comparing apples to oranges. The key factor that scientists look at for Johnson & Johnson and all of these vaccines is Johnson & Johnson was 100% effective. I want to say that again, 100. Nobody. So 100% effective in preventing deaths. Nobody died. I would say that's incredibly important. And nobody was hospitalized. Incredibly important. So you have to think about that. What is the value of that to your quality of life and morbidity? And so this is an incredibly valuable asset in addition to our armamentarium to fight COVID and to begin to bring ourselves to herd immunity. So I absolutely agree with everyone.
Yeah. Thank you, Dr. Morgan. Okay, go ahead, Dr. Rabelski.
I'm just going to say, for the public, I think it's important for us to appreciate how fortunate we are in our country, just starting here, to have such experts like our panelists here, but the scientists who have been working at these different companies. And so when we talk about trusting the scientists and the evidence, the fact is these are some of the best thinkers in the world. This is when you say, what are your options? What are your options? I would want to go with the people who know the most. And this, you know what I mean? I just think it's important not to take for granted experts of the kind we have here, experts who are working on these in the labs at NIH, Moderna, and all these places. And the thing that Dr. Morgan said that's really important is, and we finally are putting enough money and resources into it to do whatever is necessary to keep solving the problems. That should give the public much more confidence.
Absolutely, because a lot of us don't really know what's going on, and we have the scientists to give us those information that we all have been asking. Like, instead of just going on Google and Google tells you just anything, like, it's perfect to hear from a scientist or a doctor's mouth. Oh, let me tell you, I will not just be like, you'll tell Google my ear hurts. Oh, your whole ear's going to fall off next week. Like, you know what I mean? So we have to really listen to the scientists and the doctors and make sure we know exactly what's going on. I think we have another question in our comments here. We'll go into that. D Classic says, was there any testing information for people with multiple sclerosis? Do you want to go for that, Dr. Chan?
So I know that in all of the trials, they were as inclusive as they could be, as was discussed before in terms of racial and ethnic minorities, also older individuals, so those 65 and older, really trying to make sure that those individuals were included, but also enrolling individuals with underlying conditions, like diabetes and HIV and high blood pressure and others. I am not aware specifically, and I would need to look back to see if multiple sclerosis was specifically a condition that was included in some of the trials. But I know that they were very intentional, as they were in including so many of the other subgroups and individuals, to really understand what the impact of vaccine might be in individuals who have underlying conditions of various sorts, including kidney disease and others that I mentioned. I don't know if Dr. Morgan may have more information, but I'm not aware specifically of multiple sclerosis, but that's a really great question.
Right. Absolutely correct. And I sense in that question, what you're really saying is, if I have multiple sclerosis, can I take this vaccine safely? So the answer to that is yes. If you have multiple sclerosis, not only can you take the vaccine safely, we want you to have the vaccine. You have an underlying medical condition, a chronic medical condition. It puts you at greater risk of complications if you were to contract COVID. So we specifically want you to get the vaccine. So I'm sensing that within that question, that's really what you want to know. And so the answer is yes, please take the vaccine, and you should be able to move forward with that vaccine safely, any of the 3 that we have available in the United States.
And I just did what my UMBC students would do. We're doing what you would do, Percy. I just Googled it just to see what was said there. They say what you all say, but if the questioner, if the person goes to just Google's COVID and National Multiple Sclerosis Society, they talk about it and they say exactly what you all said. But just using my UMBC expertise.
There we go.
But Googling is fine, but listening to the doctors is even more important.
Exactly. There's so many different things on the internet. You can't be sure exactly what is, right and what's not. Okay, we have another question. Let's pull that up on the screen. I'm so excited about this conversation too. Lindley says, can Dr. Morgan explain the difference between community immunity and herd immunity? Because I've been hearing about this herd, and you've actually used that a lot, Dr. Morgan, as you've been speaking. What exactly is herd?
Okay. So if we talk about herd immunity is really a term that has its origins at the turn of the 20th century in farmers, cattle farmers specifically, cows, herd animals. And what the farmers noted was that, if a certain percentage of their herd became immune, didn't die from a disease and survived and became immune, their entire herd seemed to be protected. That term then was borrowed into science. And we began to understand that if you can protect a certain percentage of people in your society, and let's say in this case, we're talking about COVID. So if you can create a certain immunity level in a percentage in your society, then the virus has no point of entry into your society. And so those who are unimmunized are protected because they're surrounded by those who are immunized and the virus can't impact them. That's herd immunity. Community immunity, and I want to say before I start to talk about this, community immunity is not something with which we want to strive. We want to reach herd immunity and not community immunity. Community immunity, a great example of that is, let's say we have city A, and in city A, most of the people there have accepted the COVID vaccine, 85 or 90% of the people. And we have city B, and city B has had less acceptance. They might be at 25%, 35%, 40%. In city A, people are moving around pretty freely. They've been immunized. They've been able to take off their mask, while in city B, the people have been fairly unimmunized to the level that we need. What happens in city B is that that's an opportunity for more mutations to continue to develop. And eventually, because we are a communal society, city A and city B will have populations that will mix. City B will bring their mutations with them that could then overtake the immunity of the people in A, because their vaccines weren't trialed when all those mutations that developed in city B were around. And then we start all over again. And so that's why it's important for us to think about herd immunity and not community immunity. We really are all in this together. We don't have isolated societies. So that's probably the best example I could give of what the difference is, and why we are reaching towards herd immunity. The last thing that I would say about that is that I've heard people say, well, herd immunity will be at 85 or 90% or 75, whatever number, is decided. So I think I'm going to be that 10% that doesn't take it, and I'll be the unimmunized, and the herd is going to protect me. So what I will say to that is, don't forget that children make up a large percentage of our population, and currently they cannot be immunized. So we need every adult to be immunized, because we already know that there's a significant portion of our herd that is ineligible. So we can't afford to have any of you step out or opt out, because the children are already on the outside, and we've got to be able to protect, as part of herd immunity, those who are not immunized. Now, certainly the companies are continuing to work on children, but at the moment, there are not vaccines available for children. So I would like to encourage you to not consider that as an option, and to step in as part of these adults as we try to move towards herd immunity, because at the moment, we're the only ones eligible to take the vaccine.
Yeah. And, a lot of people say when it comes to this vaccine that they are nervous. And I am a lot of people. I'll just speak for myself. When I heard about the vaccine, I was like, okay, can I get COVID if I get this vaccine? Because, when people have received the flu shot, they're like, oh, I got the flu after I got the flu shot. So what is your response to that, Dr. Chan? Let's talk about it, because this is something a lot of people have concerns with.
We hear that every flu season, and that, well, I don't want to get the flu vaccine because the last time I got it, I got the flu. And so in neither the flu vaccine or in any of the COVID vaccines, is there any live virus that, certainly not COVID virus, that can cause infection. And so that is, the bottom line. What the vaccines do contain, and it's different versions of it, but it contains the little bit of protein that actually is what the virus would use to latch on to basically your cells in your nose to actually infect you. And so what the virus contains is basically the information that will cause cause your body, your immune system to produce antibodies and an immune response, that if the virus actually does come along, that it actually has the tools to actually attack it and to prevent infection and all of those complications that we've been talking about. But none of the vaccines that are currently available, and none of the vaccines that are being studied right now that are in the pipeline contain virus that actually can cause disease.
Yeah, Dr. Rabelski, while participating in the Moderna trial, was that a question that a couple people have maybe wondered for you?
A lot. And people were feeling that, they don't really care about you, and you're being a guinea pig. And I tell the story that when Jackie and I first went, she went right through and she got the first shot, and I was not able to get it because it turned out my pressure was high. And a lot of people of color have high blood pressure, and they had me sit there for a while. And the longer I sat there, the more frustrated I was, and so it kept going up. So they would not let me get the shot at first. It was they were saying, we care about you, and you need to get your health in order first. All right. And so I did go to my physician. He laughed at me. My pressure somehow came down, and then he gave me some more medication. And then a week or two later, I went back, and then I could get into it. I tell you that because, I mean, there will be needs for more people of color to be in other studies. You've heard both of our experts talking about the fact that they're still doing studies of different things. And I would suggest that people will be caring about people of color when they go there, and there are more and more people of all backgrounds helping in the testing process in the trials, I'm saying. And I would just suggest that people should feel confident that when they go for the trial, that people have their best interests at heart. And it's been seen over and over again. So we just got to keep getting that message out there that there are people of all backgrounds helping with the trials as well as with all parts of the process.
Absolutely. Let's talk about this flu shot mixed with this COVID vaccine, right? So for those people who have already received their flu shot during flu season and are looking to get this COVID-19 vaccine, is it okay to mix the two? Dr. Morgan, let's talk about that.
Right. And I don't know exactly what you mean by mix, but I will say.
Well, not mixed, but like, can we take, if they already had the flu shot, is it okay for them to get the vaccine shot as well for the COVID-19 vaccine?
Right. But not in the same sitting, and you need to be at least 2 weeks apart. So, so we're not, mixing the vaccines. We want to make certain that if you've had the flu shot, you wait at least 2 weeks before receiving the COVID vaccine. The other thing that I will add is the COVID vaccine doesn't protect you from the flu, and the flu vaccine doesn't protect you from COVID. So I just want to make certain that I've had that question before as well.
Okay, so we're clear on that. They're two different things right here. So we need to make sure we know the difference. Let's say tomorrow I'm going to go get vaccinated. When I get there, can I choose which vaccine I will receive? And Dr. Rabelski, I know with you being in a trial as well, I'm sure you can speak on that too. But Dr. Chan, do you want to talk about when you actually get there? Are you able to choose the vaccine?
So all of our vaccination sites have, all three of the vaccines, or they're receiving different kinds of vaccines. So we are providing that information and have asked all providers who are getting, the Pfizer, Moderna, and the Johnson & Johnson to let people know ahead of time what vaccine they should be getting or will be getting when they show up for their appointment. However, again, as we've emphasized, the efficacy and the impact of these vaccines that we are seeing from the trials, and even from some of the studies that are now coming out after the trials. So, real world situations are showing that the vaccines are very effective even in the real world outside of the trial. So I would say that, whenever people make an appointment, unless there's some severe allergy to a specific component of one of the vaccines, that they should take the vaccine that's available to them at the location that they have an appointment.
Dr. Rabelski, for you, since there are different vaccines and shipment methods, were you nervous at all about the vaccine being safe as it was shipped from place to place?
No, I think we have to, again, I'm going to say trust the scientists on determining which is best. And the news has been very good. I'm sure the doctors agree. When people have gotten the vaccine, it's been working well. I did have a question, though, for them, just because this is the question I often get. People are feeling that once they get the second vaccine, the second shot, for example, that they're safe. And I know there's a time element there. If you could speak to that for a minute, just to make sure people understand what amount of time does it take before the immunization goes into effect?
Yeah, that's a great question. Dr. Morgan, do you want to speak on that, or Dr. Chan?
Sure, absolutely. So with the Pfizer vaccine is given in 2 shots, 3 weeks apart. And then you need to wait another 1 week for full immunity to reach that 95% efficacy that you hear about. The Moderna shot is given 4 weeks apart, and you wait another 2 weeks to reach that 94.5% efficacy that we're speaking about. And the Johnson & Johnson is a single dose shot, and you need to wait 2 weeks after that single dose shot to reach your full efficacy or immunity.
And the deal is that people hear that when they first get the second shot, but people are so happy they don't remember that. It's like my students when you tell them something, okay, I'm out of here, right? And so I just think we need to keep saying that very good information, so people don't just run out and think everything is fine.
And I would emphasize that, getting that second shot, if people do get the Pfizer and Moderna, is really, really important. Is that, right now the data of the effectiveness after just one dose of either the Pfizer or Moderna is still being looked at. And so we really emphasize that it's important to get that second dose. And the other thing too, that we're already beginning to see some early impacts of the vaccine efficacy on our population. And so in Maryland, as in across the country, healthcare workers were among the individuals who were first prioritized, because we really knew that protecting that healthcare infrastructure was so important. And so even in our contact tracing data, when the cases, we usually, when we interview them, we ask, well, do you work? And if so, what kind of occupation? Back in the fall, it was maybe 25% of the cases that we had that we interviewed were healthcare workers. And now it's down closer to 10%. And that's only happened since we started vaccination. So we're already seeing, I think, some really important impacts, positive impacts of what the vaccine is offering to healthcare workers. And, as we vaccinate more people, will be able to see that across our state as well.
Let's talk about really quick those people who get COVID, right? They've already received they already have the virus. Some people think they're immune to this now, so they don't need to get the COVID-19 vaccine. What would you say to those people, Dr. Chan?
So you would still need a vaccine, because, the natural immunity we've seen does provide some protection, but we don't know how long it will protect you. It also, because we're seeing some of the variants starting to circulate here in Maryland, the vaccines have been shown to provide some protection against those variants that, you might have heard of the UK variant or South African variant. They're all here in Maryland. They're circulating. And so the vaccine can also provide protection against those variants. And so I would say, even after a known infection, if you've been infected in the past, that it's still important to get vaccinated.
Mm-hmm. And I'll just add to that with Dr. Chan, people who did have COVID were also included in the trials. So we did have people who were COVID positive in the trials as well. And so we do want you to move forward with getting immunized, because as Dr. Chan said, certainly after 90 days, the length of immunization that you have remains unclear.
Yeah,
the only
okay.
thing I'll add to that is, if you, in the course of your COVID-19, received as therapy convalescent plasma or monoclonal antibody therapy, and you would know that because by and large you would receive it as an outpatient. You're not in the hospital, and they would have put an IV into your arm and sort of run a bag of fluid into you. So something that you are likely to remember. So if you received convalescent plasma or monoclonal antibody therapy as a part of your treatment, your management for COVID-19, you must wait 90 days from those infusions before you move forward with receiving a COVID-19 vaccination.
Mm-hmm. Yeah. Have you had the COVID-19 vaccine? Let's go across the board and talk about, if you've had the vaccine, what exactly was the process for you? Let's start at the top. Dr. Morgan, what was the process for you with the COVID-19 vaccine?
So I had the Moderna vaccine, and I received it in my right deltoid, right upper arm. The first shot, I just had a little arm soreness. I am a Pilates instructor as well, sort of my side hustle, as they say. And I was able to continue to exercise, continue to teach my classes. I had no disability whatsoever. The second shot, I had more symptoms. I had much more severe arm stiffness, in that it actually prevented me from doing some of the Pilates movements where I needed to support myself, like planking. I also had a degree of stiffness. I had those myalgias that they talk about, those muscle aches. I had them in my lower back. And in fact, one night I was so uncomfortable, the second night, that I got up to take some Motrin because my back was hurting, my arm was hurting. And 20 minutes after taking the Motrin, I broke out in a sweat, which let me know that my fever just broke. I had a fever as well, didn't know it. I also had a headache for 2 mornings that responded to aspirin. None of those symptoms concerned me. In fact, I embraced them. They let me know that my immune system was working, that my immune system was revving up like an old car. We're getting started, we're jump starting you. And it was preparing itself to protect me in the middle of this pandemic. Those were symptoms that were letting me know. So I was not concerned at all. They responded just to over-the-counter analgesics, aspirin, Motrin, Tylenol. And the other thing that I will add is if you do not have symptoms after your first or second shot, please don't be concerned that your immune system isn't working. Well, what happened to me? My arm wasn't sore. I didn't get a fever. No, your immune system is working. All of our immune systems react differently. So feel confident and comfortable that you are one, in Spanish we say afortunados. You're one of the fortunate ones who had no symptoms. So be comfortable and happy in that, and continue to follow all public health measures.
Dr. Chan, what was your experience like for the vaccine if you've already been vaccinated?
So I also got the Moderna vaccine, and similarly, the vaccine itself is similar to a flu vaccine, in terms of the process of getting it. And I didn't have that much arm soreness that first day, but definitely the second day it was quite sore, and I had a little bit of trouble, raising that arm, and I had it in my left arm because I'm right-handed, so I just try to anticipate that. So I try to prevent it, from affecting my work. But, I also experienced a lot of fatigue and a little bit of a headache. But really by the second day, the arm soreness had gone down, and, I still had a little bit of headache, but that was it. I never had a fever. And I actually was checking myself, fairly frequently just to, I had a thermometer. And so I was checking. And so I didn't have a fever. But, definitely the arm soreness. I was really, really tired, especially the day after. But about, by day 3, I was pretty much back to normal and didn't have anything but, any other symptoms. And after the second dose, and I heard this in a few people, and even though I think that the general experience has been that people do get more, tend to get more symptoms, as Dr. Morgan experienced, I actually had less symptoms. So my arm was not as sore. I had a headache, but, it lasted only a few hours. So, again, everybody responds a little bit differently. And, we've heard of other, a friend of mine had a vaccine and she developed a little bit of a knot in her arm and her muscle, which was part of the response and her immune response to the vaccine. And I think she also got the Moderna, just happenstance. So our experiences are a little bit different, but but also very expected. I expected those reactions, and was monitoring for them.
Dr. Rabelski, how was your experience?
Sure. Remember, we didn't know whether we had really gotten the real deal or not. We were the placebo with all the real deal, but we kept saying in interviews, we think we had the real deal because we did. We just like both of them. The first shot was not that bad. And I'm a wimpy guy. Let me just say that. I don't like shots. All the pictures they took of us, my head was turned. I don't even like looking at the needles. So I'm just, for anybody who's a little worried. So, we go through this. And the key is this. The first time, it was not bad at all. The second time, we kept saying, we believe we've had it because we were tired. We did have sore arms. We took some Tylenol. I kept saying I felt a little loopy or spacey or something. My wife kept teasing me saying, but you're always loopy. So that doesn't count. But and we normally exercise a lot together, and we really didn't do it. And I'm impressed by Dr. Morgan said she kept teaching the class almost. Wait a minute. We just decided for a day or two not to exercise because we really felt tired. But we kept telling ourselves, well, the worse we feel, this must mean it's working. And so sure enough, we were. But I will tell you, because we took it, everybody who gets it calls us to tell us their experience. They want to say, let me tell you what I'm going through. Everybody wants to talk about it. And the same things that both doctors have said, I've heard from a lot of people, that usually the second one is a little worse. And everything from the fever to the pain in the arm to the fatigue, those kinds of things. And I just think it's important for people to realize going through that little discomfort is so much better than having a serious case of COVID and being in the hospital and dying. It is the little price we pay for this wonderful science and medicine that we can take advantage of.
Yeah.
Absolutely. And we have, go ahead.
I'm sorry, I'd just like to add there, and I didn't have this side effect, but I wanted to bring this up just to our audience because it's a side effect that's a little bit rarer, but it does occur. And it's something called lymphadenopathy, which means just a swelling of your lymph nodes. And we're having reports of those on the same side of your body. We call that ipsilateral, on the same side of your body as receiving the injection. You might get a swelling under your arm or in your neck. And it's very concerning that it could be a sign of breast cancer. It also can interfere with breast imaging. And so what we are asking is that you delay receiving a screening mammogram after you've received the COVID vaccine for 4 to 6 weeks after that second shot. If it is a screening mammogram, we're not asking you to delay therapy or delay anything that's diagnostic. But if it's a screening mammogram and it is okay with your physician to try to delay that mammogram during the time that you are taking the vaccine, in case you develop some lymphadenopathy and there isn't confusion regarding your diagnosis or your workup. Most lymphadenopathy, if you were to have it, resolves in 2 to 4 days. If it doesn't, always check with your physician. But I do want to bring that up, that issue of the mammograms, and it's same as flu shots, how you should manage that. Again, not if it's diagnostic. If this is just your annual mammogram and you have no abnormalities. If you're doing a screening mammogram, then try to time it outside of the doses of your vaccine.
We have about 5 minutes left of this conversation tonight, but I want to get to another question that we have online. Let's see. Why you only talk or show the good? Why not show the bad or failed results? Johnson & Johnson is one of the companies that have lied about the safety of their products. What do you have to say to that, Dr. Chan?
Well, I think that we have talked about some of the limitations with the trials, and there is ongoing study and information that's coming out, and we alluded to some of that we're still learning about what the longer term impacts of the vaccine might be. And so, what we're trying to emphasize is that I think with the vaccines, the goal is to prevent complications of COVID. So people needing to go into the hospital, which is never something anybody wants to do, or, dying from COVID-19. And so, the vaccines appear to prevent that. Now, does it prevent 100% of any infection? You can see from the efficacy numbers, even at 95%, it means that there's still a chance that people could get infected and could still get, some symptoms. But again, emphasizing that, the good part of it is that people are not going into the hospital or dying after receiving the vaccine. And even with the Johnson & Johnson in particular, which is the person's question, I think that, we're trying to understand, this is, there's, the evolving situation. And so with the variants, the new variants of COVID virus that are circulating now, we want to know, the good, bad, and the ugly about the vaccines. Is it effective and is it safe? And so when we look at safety, we have a very robust system here in the US looking at any of these reactions. We talked about some of the reactions that we experienced after a vaccine, which are expected, so the arm pain and such. But individuals who have more severe reactions, and so some people have had allergic reactions, for example. We look at that and we look at all of that information very, very closely, because we want to do and provide vaccine that is safe and effective for Marylanders and for everyone.
Right. I don't know what the caller or the person means by bad or good. But what I will say about the Johnson & Johnson vaccine is, don't forget, this is a viral vector vaccine. So this is a scientific platform. And viral vector vaccines have been used successfully by Johnson & Johnson in the past for both the Ebola virus and the Zika virus. So this is not the first time that they've used this technology, and they've done so very successfully. If you can recall those outbreaks, you may not be able to recall them because we've been successful in managing them. Part of that are these viral vector vaccines. So we do have a body of information on these vaccines on this platform, not necessarily on the COVID platform, but on the platform of viral vector vaccines with Johnson & Johnson.
Yeah, I think we had a great conversation today. I think a lot of questions got answered. I think that, even for myself, questions have gotten answered. Hopefully, everybody has received some great knowledge tonight. Thank you again, Dr. Jane Morgan. Thank you. Dr. Jin Lee Chan. Thank you. Dr. Freeman Rabelski, thank you so much for joining us today for today's GOVax Town Hall. Let's end COVID, Maryland. And remember, of course, we got to do this together. If you know someone without internet access who needs help with COVID-related matter, including registering for the vaccine, ask them to call 1-855-MD-GOVax for help. Again, that number is 1-855-MD-GOVax, which translates to 1-855-634-6829. Okay, if you have internet access, visit covidlink.maryland.gov to sign up for your vaccination and to get the most up-to-date information of COVID-19. Together, we can end COVID. Let's do this together, Maryland. Let's get back to whatever our normal life we can have. And of course, summertime is right around the corner. So we want a summer, right? We want something. So thank you again for everything tonight. And I appreciate you. And of course, all of Maryland and beyond appreciates you.
Thank you.
Thank you. Thank you, everyone,
Have
for
an
joining
amazing night. Thank you
Bye.
so much. And stay safe. And of course, keep your face mask on and stay 6 feet.
Right.
Please. Yes.
Keep hope alive. Keep hope alive.
Yes. Keep hope alive. Thank you so much. You all have an amazing night. Stay safe.
Bye.
Bye.